Welcome back, everyone, to another edition of the GWU JDD Dermatology Translational Science Lecture Series. I'd first like to thank our sole sponsors, Encore, for affording us the opportunity to bring such a stellar speaker today, Dr. Amy Paller. Dr. Paller is Professor and Chairman of Dermatology, Professor of Pediatrics, and Director of the NIH-funded Skin Disease Research Center at Northwestern Feinberg School of Medicine. Dr. Paller exemplifies the values inferred by the title physician scientist. Between her clinical, educational, and research endeavors, she literally has her finger on the pulse of every element of dermatology. In her limited spare time, she has served in various admin roles, like on board of directors of AAD and ADA, president of SID, Women's Derm, as well as the Society of Pediatric Dermatology. She has authored over 380 publications, and I really can't even count how many textbooks she's served as editor. She is so dedicated to academia, she flew out on her birthday yesterday to be here with us. So that says a lot. So we're so honored to have her here with us today, Dr. Amy Paller.
Thank you. Well, I'm going to fly through a lot of stuff because I decided to talk about inflammatory skin disorders, and wow, that's a lot of material, and there's a lot of new information too, which is pretty exciting, and I'll try to bring in some science as we go through. So I'm going to fly through atopic dermatitis and psoriasis, and talked about ichthyosis a little today, so I felt like I should throw that in as well here. So we'll see what we can do. So atopic dermatitis, common problem in children, about 10 to 20%. And one of the questions that parents ask at every first visit is, this is just such a horrible thing for this baby and for us or whatever. How long is it going to go on? And the studies have been all over the place in terms of those numbers. But we have a new study that just came out, which is a systematic review and meta-analysis of 45 studies. And they help us to be able to at least assure a little that the persistence of atopic dermatitis in 80% is less than 8 years of age, later age of onset, and greater severity associated with higher persistence. So a little more data, not just from one study, but really from all the studies combined that are out there. We do know that the majority of children have atopic dermatitis that is mild. That's 67%. If we go to moderate, 26% and 7% being severe, but we know then, consistent with what I just said, that as we go up in age, the severity of the atopic dermatitis tends to increase as well. And of course, some of the more recent data would suggest that adults, it's not really 2% or what people used to think, but rather is really closer to about 7%. There are even in numbers slightly above 10%. So it's not clear how much of this is new onset, but I would say most of these, I think, have had it when they were younger, maybe got better, came back. A lot of hand dermatitis, of course, too. A little word on comorbidities. Of course, we know about the atopic comorbidities. We know about the itch and the poor sleep. We also know about some of the infectious disorders that are associated, particularly the Staph aureus and the viral infections of the skin. Some more recent information, one, clearly higher risk of accidental or traumatic injury in this group. Is that because they often don't sleep well and they may be not paying attention as well? Maybe, but the association's clear and something to keep in mind. Fascinated by the neuropsychological issues that are seen. Now there have been several studies showing the association with higher risk of attention deficit disorder in children and in adults. Depression, anxiety are increased, suicidal ideation, and very poignant discussion when we were at the Inflammatory Skin Disease Summit in New York recently. There was a seminar where there were 4 adults who had atopic dermatitis severe, and one of them just talked about how many times he's thought about committing suicide. I think this is something we have to keep in mind. This is a devastating disorder. I'm going to also mention association with a variety of other non-cutaneous infections, and then some emerging comorbidities. One is obesity and cardiovascular disease in adults, and there have been some studies now showing obesity even in the pediatric population. And you think, obesity? If anything, these kids are hyper and they're thin. And well, yeah, I think that's how I think about it. I don't think about obesity. And that's because my experience with obesity is with psoriasis. We're going to get into this with psoriasis. But the ones who have psoriasis, I mean, they're really obese. They have very high BMIs, and so we think about that. But if you look at the real BMI percentiles, there is a tendency to have an increased height, but it's just not as high, so we don't really recognize it. We see so many kids, of course, who have those issues. So quick mention of the guidelines. This was really a tour de force of a whole group of people at the Academy. I was fortunate to be involved in this, and I would encourage you, if you haven't read these articles, and just keep them in your office, because it's great to have these guidelines. I'm going to focus a little bit on the pathomechanism here, and as you know, over the last several years, there's really been wonderful delineation, just like we saw a decade before in psoriasis, of what's happening in atopic dermatitis from a pathomechanism standpoint. We know about the important role of dendritic cells. We certainly know about the important role of the elaboration of certain cytokines. And although the Th2 cytokines really play a very central role, it's very clear that IL-22 is increased in these patients, both acute and chronic, plays a role, we think, in the thickening of skin, leads to hyperproliferation of keratinocytes. And in the adults, we see an increase in Th1 as well, particularly with greater chronicity. We know that we see a decrease in the ability to have an antimicrobial response, certainly compared to what we see in another inflammatory disorder, that's psoriasis. And we see a decrease in filaggrin. Of course, 10% or possibly a little bit less of patients have a filaggrin mutation, generally a null mutation that decreases their amount of filaggrin in the skin. But others have been shown to have, across the board, decrease in filaggrin expression that's been linked to both the IL-4, IL-13 elaboration in the skin, and then also Staph aureus can drive down the expression of filaggrin. So all of that's thought to play a role. Now, all of these studies, every one of these observations has been based on biopsy of adult skin. And we have no idea, we've had no idea, whether these are issues that are seen in children, particularly young children with fairly early onset. So what I'm going to tell you about is some of our recent data, because we asked the question, are the changes in early atopic dermatitis the same as what we classically think of as triggering this disease, or very important in what we see, but it's all from adults. So I thought I had another thing coming up. At any rate, we did a study where we collected skin. We also collected blood from patients with atopic dermatitis who were 5 years of age or less and had the disease onset within the previous 6 months. And we compared these changes to age-matched control skin and blood, non-atopic, to adult atopic dermatitis, and to adult psoriasis. And we looked at both lesional and non-lesional skin in doing this. And the first surprise was that even though this was a relatively more recent onset, and we're not thinking about this marked lichenification we can see early on, there was just as much epidermal thickening. Let me see if I can do this with a, can you see that? No, that's not doing anything. Okay. I know, but I can't do them both. Okay, so I'm just going to do it on this side. If I do it on this side, can you guys see? Okay, so at any rate, there's just as much epidermal thickness if you measure the thickness of the epidermis in histologic sections. You can see when I show you these images, the bar with the asterisks basically is comparing to control skin. If we have longer bars, from where it starts to where it ends is what the comparison is, and we have reaching up as high as less than 0.001 for 3 asterisks and then going down from there with one asterisk being less than 0.05. So since I can't as easily point both ways, that's what's going on here. So if you look at the non-lesional skin in pink, whether we're talking about adult adult atopic dermatitis as seen here, or the pediatric as seen on more closer to the left, and then the gray are your controls. So what you can see is epidermal thickness, certainly in the case of lesional skin, much greater in both adults and in children compared to control skin, and certainly versus lesional skin as well. And then you can see that when we look at K16 as a marker of increased proliferation, not only is that difference seen, as I just talked about with epidermal thickness, but it's actually even greater in the non-lesional and lesional skin than what we see in adults. And we can similarly look at K67 as another marker of that. Now, if we look at the infiltrates that are in skin of these children, we again see similarity to the adults in that there's increased CD3 as a marker of your T cells, and there's increase in CD11C as a marker of Langerhans cells, both in the lesional skin compared to controls and in lesional skin compared to non-lesional skin. And then when we look at your Th2, with IL-13 being the best marker of that in skin, and we looked at several, of course, we can see similarly, as with adults, a lot of Th2 activation or expression, I should say, in the skin, and actually more of IL-13 as a marker of Th2 in non-lesional skin in children than in adult non-lesional skin. And we see the same pattern with IL-31, which, as you remember, is predominantly Th2 cytokine, but one that's been linked to the itch. And then IL-22, that marker that we've associated with thickening of the skin. Again, the same pattern. Up as it is in skin, as in adults, but actually even more in non-lesional in children than in adults. Now, if we go to look at the blood, we see some similarities and some differences. Well, we see that there are actually reduced numbers of cells that express Th1 in early atopic dermatitis versus controls. And specifically here, we're looking, remember, you can have markers on cells for CLA that are the skin homing cells that are in the blood. So CLA positive cells are the cells in the blood that home to skin. So if we specifically look at that, we see reduced skin homing Th1 cells in early atopic dermatitis versus in controls. And if we look at the Th1 cells, they're actually reduced more in children than they are in adults, except if you look at a severe group of adults, and they are the ones who actually have the greatest reduction in the Th1 cells. And this Th1, Th2 imbalance in specifically the skin homing CD4 positive T cells is more pronounced in young children than in adults. Now, if we think about the atopic march, this is this concept of having early atopic dermatitis and then later having the risk of developing other forms of atopy, your food allergy, your asthma, your allergic rhinitis coming up over time with age. And there's been some controversy about it. Clearly, everyone who has atopic dermatitis doesn't go on to develop this. And very important, clearly there are many people who never have atopic dermatitis who go on to develop allergic rhinitis or asthma. And the order may not be like this either. There are kids who get evidence of atopic dermatitis after developing some other form of atopy. But nevertheless, this atopic march occurs in many children, and I'm going to come back to this again later.